Thank you so much for having me. I will start with a disclosure. If you want to know anything personal about me, there's about 4 things in my life that I regret, and one of them is not having learned French. It's the truth. It's the truth, and I think the number 4 is pretty much correct in this case. I will not use a lot of other numbers today, unfortunately. Despite the fact that we are talking about statistics, I will speak about something that is a bit broader. And before I start, I changed the title a little bit here because we want to make it a little bit more attractive, and many of you will know what the origin of the theory of everything is. It's actually coming from physics. But before I start, I wanted to thank Philippe and Isabelle for the invitation to be here today and the opportunity to come to Paris. It's truly remarkable. We had time yesterday, and what the CRESS has done and accomplished in this very short period of time is incredible. So I feel extremely privileged. But before I continue, in the past when I worked at McMaster University, where I'm now emeritus, I always had to show a slide where McMaster University is located, and this is one of the big things that has changed in my scientific life. I don't need to show this slide again because most people know where Milan is. I start with a few disclosures. I chair the GREAT working group, and we'll talk about this a bit today. I also have affiliations with the Guidelines International Network and work quite a bit with WHO, an organization from which I've received research funding and consultancy fees. But I think that most of my conflicts here are quite extreme in the intellectual category. So I will talk about expand on an article that we published a couple of years ago in the Lancet Public Health, which carries the title that is the original for my presentation. And it goes back to something that is, we think, quite overarching, and it relates to that clinicians, the public, including patients, in particular if we talk about public health, policymakers, payers, regulators, and the science community at large influence or make a lot of decisions. We don't make all of them because what happens behind closed doors when politicians make decisions is sometimes not very clear, but we influence a lot of them. And we do this at various levels. So health technology assessment and systematic reviews, of course, guideline recommendations, coverage decisions, selection of essential medicines, which is particularly relevant for low and middle income countries, and diagnostics related to that when we create policy briefs and when we do quality improvement. So the goal of our work was, because in particular in the context of the World Health Organization, the goal of our work was to think about the concepts that these different decision makers are utilizing to end up with recommendations or decisions. And we did this starting really, the idea came through a lot of work that we did in a very small country, Estonia, with, in particular, the Health Insurance Fund that is both a HTA group as well as a payer. So the background to this work is this work that we did in Estonia and, of course, with many other countries that we visited over time in the context of evidence-based decision-making. And I'll start with this very concise example. The Estonian National guideline program, or Estonian Health Insurance Fund that sponsors the program, about 7 years ago or so started to evaluate new anticoagulants for the prevention of stroke primarily, with all the downsides that are there, in patients with atrial fibrillation, which is essentially a irregular heartbeat that puts you at a very high risk of stroke. About 15% of 80-year-olds have atrial fibrillation in the general population, and the risk of having a stroke is about 10%, depending. There's lots of risk stratification, but on average, so it's a pretty high risk. So they were evaluating this new intervention or fairly new intervention, and they made a conditional recommendation because the cost for this new drug, despite the fact that it was much easier to administer and equally effective to our standard treatment, which was warfarin, because the costs were considered to be too high. So as opposed to strongly recommending that these patients would receive that type of intervention, they made a conditional recommendation. Price negotiations ensued with the Estonian Health Insurance Fund, again, between industry and health insurance fund. The manufacturer lowered the price, and they changed the recommendation to a strong recommendation based on the health benefits and harms. At the same time, there was a submission that we did actually to the WHO Essential Medicines list, which is one of the few really fundamental tasks of WHO that member countries asked WHO to undertake, and it was rejected. It was rejected because the evidence was considered to not be yet sufficient and for a bunch of other reasons. A few years later, 4 years later, this essential medicine list started to approve the direct oral anticoagulants. So you see how on national levels and international levels, decisions are made about specific interventions, and they are not always totally aligned, and they are influenced by many factors. We did another piece of work. I have close colleagues in Brazil, and we were working a lot in the guideline field and realized in this context that in this guideline field, different actors in the health system were not aligned. So we did an evaluation of the Brazilian health system, looking at how they do health technology assessment and guidelines. And interestingly enough, they were both in the Ministry of Health. They were both on the same floor, but they did not know what the other group was doing, which was quite remarkable. So we did a typical SWOT analysis with these groups, brought these groups together, and all of a sudden they realized that they were using very similar processes, evidence synthesis, and that it would be maybe much better if they started to build on each other's work and make decisions together. So again, our approach to creating an underlying theory for this decision-making in the health ecosystem was to work with WHO and bring in representatives of different areas. It was difficult because we had planned for a big meeting, and then the pandemic came, so we had to shift this to online and make it smaller. We discussed how the evidence that influences the decisions and the actual decisions relate to each other. We looked at the factors or decision criteria that influence the decision, the type of evidence that might be required and where it comes to play, and who is actually making these decisions and in what context. And it became very, very obvious that all of these decision makers that we started to talk to are, of course, interested in the best evidence about benefits and harms of an intervention. That includes, of course, how much value people place on particular outcomes. So it's not only risk differences based on some baseline risk, but it is also how important the outcomes are when we evaluate benefits and harms. What the magnitude of the required resources would be. That is also very common across the different systems. And increasingly, the recognition that equity, including societal implications and perhaps inequity in terms of environmental impact, are playing a greater role. This has to do with acceptability of interventions to stakeholders and whether or not things are feasible, if you think of the political context, the system, the societal context, and so on. So, and this, when we did this work, it became pretty obvious that that was very much related to what we had done with the Great Working Group. Let me just check with you. Who of you has heard of the Great Working Group? Okay, that's about 30% of you in the room. Okay, so I'll spend just 1 minute. So GREAT is a system that we have developed over the last 25 years now almost, that is trying to make evidence assessment transparent and bring clarity to decisions. We started working with big organizations from the start in 2000, professional societies and major health organizations such as the WHO that accepted GREAT or started using GREAT officially in 2003, so quite an early adopter. GREAT is for systematic reviews, health technology assessment, and guidelines. It's been used in thousands of recommendations. We have a lot of citations to our work. We have a new updated book, which is called the GREAT Book, available online for free, of course, and we have applications. And we now have over 30 centers and networks globally that support those who use this method in various ways. So we are on all inhabited continents at this point. And I'm mentioning GREAT because when we did this evaluation of what criteria influence decisions, we realized that much of that we had already covered in our evidence to decision framework or evidence to decision work that was funded by the EU from 2010 to 2015, and where we had published a whole bunch of different papers on how decisions are made in the narrower health context in different scenarios. So public health, clinical guidelines, health systems decisions, as well as coverage decisions. And this was our framework back then, where, again, it was a bit narrower focused on what was about guidelines, coverage decisions, and here a particular case of diagnostic decisions, where we had these criteria that I mentioned earlier, described. But in this theory of everything work, or in this ecosystem work, we realized that there are obviously much, much more actors, as I already described, beyond health technology assessment and guidelines. And that the decisions are so much more complex than when we sit with a guideline panel, which is already pretty complicated, but when we sit with the guideline panel and evaluate the evidence and come to a recommendation. So we developed what we call our theory of everything in health decision-making. This comes from physics. Those of you have, there's a very well-known book by Stephen Hawking, Theory of Everything, which has not been fully figured out, but we haven't figured things out. No, we have not figured things out as well. But we think that there is, that this theoretical framework can help with bringing actors together. I don't know exactly how it is in France, but we know from many case studies that we did in countries that these blueprints for who are the actors in a health decision context, who the actors are in a health decision context in a country is typically not available. So our overall goal was, as I said, to lay out these concepts of decision-making and go beyond established partnerships that sometimes existed, sometimes had to be created, like in the Brazilian case. And this is what we came up with, that obviously evidence from primary research that answers particular healthcare questions, typically formulated in our population intervention comparison and outcomes format, that evidence from primary research requires evidence synthesis, typically using systematic review methods. And that in an advanced health system, these different actors that make decisions or recommendations would use systematic review methods to summarize primary research. And the actors that we determined initially in our early work were obviously the health technology assessment groups, guideline developers, but quality improvement plays an enormously important role. Most quality improvement and insurance agencies use guidelines, but they don't really assess them for how good they are. To be frank, coverage decisions that are already mentioned, the essential medicine list, but then there is, of course, evidence-informed or evidence-based policymaking. And these groups, as I already described, use these evidence to decision criteria, the criteria that I describe here, how important the problem is, the benefits and harms related to an intervention, values, costs, and the certainty of the underlying evidence are connecting themes across these different actors. What differs are the more contextual factors, oftentimes at least. So in health technology assessment, we often look at ethical and legal context, and in policy making, equity and feasibility are often more highlighted. But in reality, you know, these criteria are probably also quite similar across these different groups. They often have different terminology, and I can tell you terminology is a big problem in connecting even in a narrower space such as health, because people use different terms and think that they are talking about something different. So different terminology for often the same context. Most of these groups use modeling to arrive at some sort of conclusion. These first two actors here oftentimes end up with recommendations. I apologize, the font has shifted a little bit. I'm a Mac person. End up with recommendations. These other groups often make decisions. Policymakers don't like to be told what their decision should be. They like to be presented with options. So we called it options here. And of course, recommendations lead to decisions, oftentimes by these other groups. I mentioned the Estonian example where the guideline and HTA group ended up with a recommendation, and the coverage decision maker, in this case the Estonian Health Insurance Fund, made a decision to not cover it, right? Because of cost, until the price negotiations took place. And these are products coming out of these health decision makers. Another very particular role is played by regulators. So regulators such as EMA in Europe, or the FDA. There are lots of regulators around the globe. And these regulators also use similar concepts to make decisions. Of course, for them, oftentimes, it is about whether or not there's a potential for an effect. They typically don't look at cost as explicitly, although then negotiations take place depending on the health system that you work in. So regulators, not only in the drug market or in the intervention or technology market, but also in the exposure field, such as toxicology, and if you think of the European Food and Safety Authority, they make recommendations based on these concepts for what are tolerable, for instance, levels of potentially noxious substances. And we bring this to the clinical field, the public health field, and the health systems field. I should have checked my spelling better, my wording better here. These are the users who then, of course, work on implementation. And our first view of this ecosystem of health decision-making stopped there. And I'll tell you where we have gone from here. I wanted to give you a couple of examples for where connections can be made and have not typically made. So many of you will work in the clinical field and in clinical trials, and one of the areas that we had identified fairly early is that there's a complete disconnect between these different actors in terms of what health outcomes might matter to people. And they all use different outcomes, different definitions of outcomes, and that creates a lot of problems also for primary research. So the way to think about it is that when we, for instance, define what a stroke means to people, in other words, a cardiovascular event that affects the brain, either ischemically or through a thrombus, when we define what a stroke is, we should always have the patient or the person affected by it in mind. And the definition of severity of a stroke and what people experience and what the consequences are should probably start with that person at the center. In other words, I'm thinking about person or patient-centered medicine. But then the way that we define, perhaps together with some patients, the severity of conditions and descriptions of a condition, that all will have to be used by the different actors that I just described. So health technology agencies will use will look at these outcomes and make decisions based on that. In clinical care, we often present descriptors of health outcomes, guideline recommendations, formulate questions, these PICO questions, having certain outcomes in mind, and then, of course, the primary research. But this is also true for quality improvement and, of course, for systematic reviews. I'll give you a quick example of what we are referring to. So this is an example. Now, this is fairly small to read. I didn't know how large the screen was, but this is an example from the European Breast Guidelines, an initiative that is done by the European Commission, where we started early on to define outcomes from a patient perspective before we started necessarily looking at the evidence, right? That doesn't mean that the evidence is not useful, but it means that we sometimes have very direct evidence and sometimes we have indirect evidence. And these simple health outcome descriptors from a patient perspective describe symptoms, describe a time horizon, what follows in terms of testing and treatment, and what are consequences. And having standard definitions that not only relate to clinical trials, perhaps in systematic reviews, will help connecting these different actors. And there are these different actors, with regards to this standard definition and how different groups can use it, it will be very clear that sometimes information will directly relate to this outcome, and sometimes it will be a little bit more peripheral or indirect, as we would say. But having standard definitions will help bringing these different actors together and understanding what they are actually interested in. That is one example. The other example that we like to use in this context is, again, coming back to quality improvement and assurance, relates to how we can relate our original research question to measurement of quality, in other words, quality indicators. And so this is from a framework that very much fits into this overarching theory of everything, where our original healthcare question, again, we use, PICO is a simplistic way of saying, you have to develop a good healthcare question that specifies the interventions, but where we started to relate outcomes directly to quality indicators, which are pretty much identical with the actual outcome. So it's a construct that is used to guide, monitor, or evaluate, or improve the quality of services. Performance measures that can be directly derived from that, which are basically tools to quantify or describe measurable elements. And then performance indicators, which are the measurable units in order to measure quality. And to give you a very quick example, if one outcome was health-related quality of life, patients with stroke, that would be your construct. Your tool might be the SF-36, that is a generic health-related quality of life instrument. And your performance indicator would be that all patients receiving this type of therapy should be having a score of more than 60 or something like that, right? Or 90% of the patients that you're treating. So, and this field of quality assurance and improvement, I don't know if any of you work in this, is typically picking these quality indicators somewhat disconnected, in a somewhat disconnected way from the HTA groups and the guideline groups. And in particular, as I said, over the years, we've realized that they don't typically even assess guidelines for quality. It's changed a bit. So, and as an example for where we are starting to apply it is indeed with European Commission work. The European Commission is not only working on breast guidelines, they have now 6 guideline cancer screening and prevention and diagnosis guideline programs. And the second one was the the colorectal cancer screening and prevention guidelines. There's cervical cancer, there's prostate cancer coming down the line, gastric cancer and lung cancer. these initiatives are quite important, and we've actually started to bring together there the systematic review community, HTA, guidelines, doing some modeling. Modeling is complicated, using these health outcome descriptors to connect also to quality assurance, and this will have an impact on coverage decisions, we believe, but we haven't necessarily done that. And of course, this leads to policy. So if the European Commission makes guidelines centrally about screening and prevention for colorectal cancer, different age groups, different tests, policymakers in the countries will look at them and say, okay, this is what we're going to do and this is what we are not going to do. And this has already been pretty proven. So in this context, this is our typical graph, our typical grade overview. This process involves evaluating, setting PICO questions, and not only setting the PICO questions, but starting to think about quality indicators, do systematic reviews for outcomes that are critical or important for decision making, start thinking about the candidate performance measures, use, in this case, great evidence to decision frameworks and evidence profiles, assessing the certainty for both the outcomes related to interventions as well as the information, the certainty that we have that quality indicators and performance measures can actually make a difference. Use these evidence to decision frameworks, make recommendations for both health interventions as well as what quality indicators and performance measures should be used for an integrated guideline and quality assurance. I wanted to come back to our this theory of everything in this context. What we have then learned with trying to apply over the last years this theory to different to these different contexts is that we could put a matrix over this because there are so many research gaps that we need to address that relate to developing tools. Looking at the right health questions, and of course research methods. I will give you a very quick example about that. And that we need to start mapping systems, from France to Italy to Tanzania, and are doing this now under the auspices of a new WHO Global Coalition for Evidence. One quick example before I will kind of sum it up, but one area that we have identified relates to how we assess benefits and harms across these different actors. So I will come back to that in a second, but we'll also list what primary research gaps we believe exist there that are far more complicated than just doing an evidence synthesis. So the health economic considerations across the globe are complicated, need to be prepared appropriately so that we share evidence in a way that others can make decisions. I highlighted these decision thresholds related to health benefits and harms, and we'll give you a quick example. There is lots of things that we do not know about how groups make decisions. When I'm being asked as a guideline methodologist who should be part of your guideline panel, I say you need to be multidisciplinary. And then we refer back to work that is pretty old, 15, 20 years old, and this work is not actually very well done, right? So there is so many gaps in terms of how and who we should involve people that very much relates to social sciences. That evidence needs to be compiled, and we need to do more primary research about that. I mentioned the cost effectiveness and how we bring foundational science into this, as well as the clinical research. So very quickly on these decision thresholds. So when we sit with decision makers, guideline panels, HTA, at some point the group that is assigned to make a recommendation makes judgments about how large benefits and harms are in order to balance them. And in this ETD work, but this is pretty common, we use three categories beyond that there is maybe trivial or no effect. And we call them small, moderate, and large effect. Cohen already did that with his effect sizes. And this is true for both benefits and harms. But the question when we sit with these guideline panels is what really is a small effect and what is a large effect in order for us to balance. And of course, for those of you who work in decision analytical modeling, it would be much better if we had decision analyses for all of our decisions, but I can tell you the reality is, in the fewest cases, does a guideline panel or even any of these other groups have a really fully valid model at hand. So we make these judgments in a semi-quantitative way because the modeling doesn't typically exist to the extent that we need it for a guideline panel. So what are these, what should actually move us from saying the effect goes from small to large? So we call this decision thresholds, the thresholds that determine these transitions. And here's a very quick example from a global tuberculosis guideline where we define these decision thresholds ahead of time and then look at what the evidence synthesis reveals in terms of how large potential benefits are, reduction in death and reduction in tuberculosis complications against serious adverse events. And these thresholds are determined, as I said, ahead of time in order to then say, okay, there may be two small benefits and there's a small harm overall that possibly leads to making a recommendation in favor of this intervention. So this is the only quantitative aspect. Again, I'm happy to talk more about these decision thresholds. And then I want to finish with where we are going next. So this was our original model. We just very recently held a meeting, now expanding into low and middle income countries. Philippe was we were privileged to have Philippe there to see what we need to do next. And a few things became very obvious. First of all, that it's not really systematic reviews, but different forms of evidence synthesis that are required, and we changed the terminology there. Ethics play an enormously important role. We are currently trying to figure out what ethical frameworks we should be utilizing in this context. Planetary health is playing a significantly important role that it probably deserves in any health decision its own evaluation. And the methods for which have to be figured out. What I'm talking about is when you use an inhaler, are you using a greenhouse gas emitting inhaler, or you're using an inhaler that doesn't do that, right? That has impact on the planet, and health guideline groups should be considering these things. That it's much more not only about the clinician, but it's about the public, of course, and how they interact with the clinicians. That this type of work that is being done by these agencies should be informing what primary research is done, and of course that there is lots of need for setting priorities in terms of implementation research that we are learning from the implementation of these interventions across these different actors. So I want to finish with actually this one. So there's, and thank my colleagues from this recent workshop. Not everybody who was part of the original work is on this picture, but there's lots of people who have contributed to that, and it's a great group. We will create a community around this, this particular field, and of course, super happy for anybody to join. Thank you very much.